Hello. Hi everyone, Dr. Amin here from Toronto. We're going live. Happy Wednesday. Another beautiful day here in Toronto. Hope everyone is good, happy, and healthy. So, we're going live with Dr. Teplinsky today to talk about breast health and all your questions. I received many questions over the last 2-3 months, so I'm going to address all the concerns if times allows us. I know Dr. Teplinsky is very busy, but we try to answer as many as possible. If you have any questions about breast health, any issues, as always, I say this is not a medical advice, but it's just education for you, so to empower you and be able to ask all those questions and details with your doctor and address your concerns. So if you have any questions, you can drop it in the comment or in the question bubble, and if we had time, of course, we're going to go through some of those questions. I'm going to invite Dr. Teplinsky here now. Hi, Dr.
Hello.
Teplinsky. How are you?
I'm good. How are you? All right. Can you see me
Good,
fully?
thanks.
Yeah. Okay.
I see you
Okay.
very
Awesome.
well. Very well. Great. So please introduce yourself to us.
Sure. So thanks for having me. I'm Eleanor Teplinsky. I'm a breast and gynecologic medical oncologist in New Jersey, and I'm really excited to talk about breast health, any breast cancer screening questions, breast cancer risk, anything that people want to talk about.
Yes, that's
Mhm.
great. Thank you for coming here. I know you're very busy, but I received many questions. I knew that we're going to talk, so a lot of questions. We go through some of them, especially considering breast cancer is number one cancer for women in worldwide and number
Yeah.
one
Mhm.
cancer-related deaths too. Um, so one of the questions I receive is about always risks. So what are the main risk factors for having breast cancer? We see it more and more in younger women nowadays. Is it because what is it? Is it detecting them earlier or something else is going on?
Yeah, so lots of great questions. I mean, we know, there's so many factors that go into breast cancer risk, but the two kind of biggest factors are age, and being a woman, and so being female. And as we get older, the risk increases. Now, we are seeing younger and younger breast cancer diagnosed in people younger than 50. That number is on the rise. And we don't really know actually why that's happening. It's not because of earlier screening, because we're seeing, or better screening rather, because we're seeing in people who are diagnosed before the age of 40 when they were not even going to be going for their routine screening mammogram. But there are a number of things that kind of go into risk. And I like to break it down into modifiable risk factors, so things that you do have control over, and non-modifiable things that you don't have control over. So what falls into that non-modifiable category? Your genetic history, your family history, to some degree your reproductive history, because getting periods at a younger age increases your risk, and so we can't control that, and we're actually seeing girls get their periods younger and younger, and that may play a role. At the age at which you have children, how many children you have, and again, to a large degree that is not modifiable. So these are all things, kind of reproductive history, family history, genetics. And then in the modifiable, these are the lifestyle things that we do actually have a fair amount of control over. So things like alcohol, lots of headlines in the news recently about that alcohol is a carcinogen, and alcohol really increases breast cancer risk. So that's something that we talk about. Exercise or being physically inactive or leading a sedentary lifestyle can increase risk. Diet, nutrition, weight, all of these things play a role. And so there's more, but that's kind of a brief overview. And the biggest thing is it's really important to make sure that people are talking to their doctors about their breast cancer risk. There are calculators available that you can plug in all that information. Your breast density is a breast cancer risk factor, so you can plug in all that information and they'll give you your risk. Now it's estimated. It's not perfect by any means, but it's one piece that we can use. But it's really important that people have those conversations with their doctors.
Mhm. Great. So I think some were asking about family history. Maybe they get their answer. So they was asking someone, if no one in my family has had breast cancer, am I still at risk? And also opposite, if someone has a family history, is it more at risk? Is she more at risk?
Yeah, so a lot of times people will say just like that, there's no one in my family who's had breast cancer, or I don't need to go get my screening mammogram, or how did I get diagnosed when there's no family history? And, most cancers are not genetic. Only about 5 to 10% of breast cancers are hereditary. And we know that cancers can run in the family even if there isn't a known genetic mutation, but you don't need a family history to be diagnosed. And so absolutely should be getting your screening mammogram. And while having a family history, especially in the first degree relatives, so mom, sister, increases your risk, nothing is a definitive that you are going to be diagnosed, but it increases your risk. So that's where we start thinking about, do you need high risk screening? Do you need to get genetic testing? And again, it just comes back to that conversation of really making sure you're discussing your breast cancer risk.
Mm-hmm. So now about the screening you mentioned. So what is the best time to women start screening, and what is the number one screening test? We hear so much on social media about different types of screening. So it's a bit confusing for women.
Yeah, so for average risk women, the recommendation is to start breast cancer screening at age 40 and doing it once a year after that. And there are different guidelines that are available, but these are the ones we mostly follow. And then if you have dense breasts or you're high risk, we might add additional imaging to that mammogram. So we might get an ultrasound or an MRI. If you are high risk, then you might need to start before the age of 40. But we don't know that until we figure that out for each person.
So it's very personalized. We want to calculate the risks and then decide what type of screening is the best. That makes very sense. And again, very common question. I'm a menopause specialist myself, so this is very commonly about hormone replacement therapy or menopause hormone therapy nowadays. We call is that cause breast cancer. So a lot of women concerned about hormones and what to do. Should they start, or is it a risk factor for breast cancer?
Yeah, I mean, I think, that's the $1,000,000 discussion, right? And I think that we can have a whole conversation about this alone. But what we now know, 20 years ago, the Women's Health Initiative study was published, and it just sent everything into tailspin. And people, the headlines said hormones cause breast cancer, and that is, completely was misinterpreted, and people stopped using hormones. And I think now it's pivoting again to, hopefully getting more people to use hormones if they need them and want them. But what we know is that there's two different types of hormones we can do. We can do estrogen alone or estrogen with progesterone. So estrogen alone, menopausal hormone therapy, does not increase breast cancer risk. It may even reduce breast cancer risk. If you do not have a uterus, then you can take estrogen alone. Now, estrogen plus progesterone in the Women's Health Initiative study did have a very slightly increased risk of breast cancer. But look, that data is 20 years old. It's different formulations than we use now. And it's really that progesterone that increases the risk. And we don't use that same synthetic progesterone, that we used back then. And so I think that it's hard to know exactly what the risk is now. But the most important thing is that just because it's a slight increase in risk potentially should not preclude someone from going on hormones. And I think, again, this comes down to talking to your doctor about your risk. But I often hear patients say, I was told because my mother had breast cancer that I can't have hormone replacement therapy. And that is absolutely not true. So having a family history, having a genetic mutation, having even a higher risk condition, those are not contraindications to using hormones. The only place we're still really cautious is that patient who's already had breast cancer, and specifically hormone receptor positive breast cancer.
Someone asked about density of the breast,
Mm-hmm.
and so is it higher risk because it's harder for screening? Is it harder to detect cancer, or is there something other reasons for
So actually
higher
a
risk?
little bit of both. So about 50% of the population has dense breasts, and we know that as we age, the breast density can decrease over time. But having dense breasts is a breast cancer. It's kind of a double whammy in a way, because we know that having dense breasts increases your risk. It's not exactly clear how that happens, but it increases your risk. But also it can make it hard to detect a cancer on a mammogram. So you're a little higher risk and it's harder to see that. So that's why in those situations we will think about supplemental imaging. The challenge is that, and every time I've shared about this, people will say, well, I have dense breasts and my insurance denied a mammogram. Denied an MRI, or my insurance denied an ultrasound. And so I do think that there are some limitations in this, but the goal is to get people to know what their breast density is. And the only way to know is to have a mammogram, and it's going to be reported on your mammogram. Some people say, oh, I have, my breasts feel heavy, they must be dense. And those two things are not linked at all. And so then looking at your mammogram report, then saying to your doctor, I see here it says I have dense breasts. Can we talk about what that means for me? Can we talk about, the role of maybe doing supplemental imaging?
Mm-hmm. Very good. And then someone is saying about recently has been diagnosed with breast cancer and is going through some tests to figure out is it hormone positive or negative. So do you mind to explain a little bit about the difference and then how the management changes if it's one negative or positive?
Absolutely. When we know that someone has a diagnosis of breast cancer, the next thing we want to look at is the marker status. So we want to check for estrogen receptor, progesterone receptor, and HER2. These are kind of the three big markers that we look for. And depending on if you are hormone receptor positive, which is estrogen and progesterone, if you're HER2 positive, or if you're triple negative and you don't have any of the three receptors, the treatment's going to be driven by that information. So about 70 to 80% of cancers are hormone receptor positive. And that means that when we think about our treatment, part of our treatment is going to be hormone blocking medication, because if there are any residual cells or cancer cells around, they're going to feed on estrogen. And so we want to block that process from happening. But the treatment really depends on the type that you have, which is, based on that testing for those markers.
Mm-hmm. And I loved one of your videos, all of them, but one of them about this treatment or adjuvant. So if you don't mind, explain a little bit about that. And I love to hear it myself again.
Yeah, I think that the way to think about breast cancer treatment, and this is what I tell all my patients when they come see me for a new patient visit, is, when we think about treatment, we really have two categories. The first category is we want to get rid of your cancer, right? And then the second category is we want to keep it from coming back. So that's for stage 1 to 3 cancer. For stage 4 cancer or metastatic disease, the goals are different. We want to control the growth, because that in stage 4 it's spread outside of the breast and in the armpit, so it might have gone to your bones or your liver or your lungs, and we want to shrink it. We want to make it as small as possible, and we're also balancing quality of life, because you're going to be on treatment for a longer period of time. But for stage 1 through 3, we want to get rid of the cancer, so that's usually a combination of surgery, maybe chemotherapy, and then we'd like to reduce the risk of it coming back, and so that will sometimes be with radiation, with hormone blockers, with anti-HER2 therapy, with more systemic therapy. And so the treatment and how we sequence it depends on your stage, the tumor size, the lymph node status, the estrogen, the progesterone, the HER2, and so forth. So we put all that together, and we have very clear guidelines for where can we operate first, where do we need to give upfront chemotherapy, where do we need to give upfront immunotherapy. And so it's really so individualized for each type.
And then the questions about the side effects and then how to manage some of those side effects. I think this is a very, as a family doctor, I see again a lot of women
Yeah.
in my practice with side effects of these treatments. And then that's a question how to manage those.
Well, and I think that's the hardest part, and I'm sure
Yeah,
you see that,
yeah.
all the time, because these are medications, especially the hormone blockers that people are going to be on for 5 to 10 years.
Mhm.
They lower estrogen levels, and it can make it really hard. And we're talking, day-to-day side effects like hot flashes and joint pain and the genitourinary syndrome of menopause, vaginal dryness, mood changes, osteoporosis. And then again, long-term things like your bone health, and people worry about their hearts and their brains, and so it's really everything. And in terms of how we manage the symptoms, I will say a lot of patients, sometimes feel not left out, but they feel like the menopause conversation is hormone driven, and hormones are relatively contraindicated, and so um, they feel like, well, where do I fit in, right? How do I protect my heart and my bones and my brain and my hot flashes if I am not a candidate for hormone therapy? And so what I want to say is that we do have really amazing ways to manage these. We have non-hormonal medications for hot flashes. Vaginal estrogen is safe to be used. It doesn't, the very limited systemic absorption. We feel very comfortable using vaginal estrogen. So hopefully people are not suffering with genitourinary syndrome of menopause. And lifestyle is a really big piece. Thinking about how are we moving our body, how are we sleeping, how are we managing our stress, what food are we eating, all of those things play a role. One of the things that we also sometimes, there's so many other contributing factors to a lot of these side effects. So, for example, sleep apnea.
Mhm.
I'm sure you see this in
Yeah.
your practice, right? It's so underdiagnosed,
Yes.
and people are suffering. They're not sleeping. They're waking up exhausted. They're having trouble exercising, and they're gaining weight. And you know what? And yes, their breast cancer medicine may be contributing, but also they've got this undiagnosed sleep apnea. So it's really thinking about the person as a whole and figuring out, all right, what's going on? How do we address your symptoms? I think that one of the challenges with these medicines is weight and metabolism issues. And the GLP-1 medications can be really helpful for some patients. So I think there are so many things that we can do, but it takes time, it takes effort, and it can be really hard.
It is very hard, and I
Mm-hmm.
see many women suffer from hot flashes and bone
Mm-hmm.
problems,
Yeah.
and many of them. I have not seen any of my patients, at least, who, even if it's safe, willing to try hormones. It's so no. So, as you mentioned, there's so many other
Mm-hmm.
things that we can use. I have a lot of women on FX or
Yep.
vaccine
Mm-hmm.
that
Yeah,
for
that's a
hot
great one.
flashes and also mood, anxiety, and depression, stress that they're going through, the
Yeah.
treatment, and
Mm-hmm.
all the PTSD after. I think that would be a good choice, and a lot of women like it. Less side effects and
Yeah.
less. I mean, weight gain is one of the problems we have, but comparative to other SSRIs and antidepressants, less, I see.
And I think that, the other piece of it too is like leaning into all of the other complementary therapies that we can use. I find acupuncture, physical therapy, can be so helpful and beneficial. Mental health counseling, talking to someone, because as you said, there is the mental health impact. The mind body connection is so real, and often there's trauma, there is processing what's happening, there's grief, there's anxiety, there's anger, there's loss, and it can be really hard for things to improve physically if mentally they're not improving, or vice versa. And
Mhm.
so I think recognizing, okay, how do we take care of the patient as a whole? And I think honestly it's hard to do this because there's so many factors, and I don't know about you, but in the US, the visits are short, and it can be really hard to kind of figure out how to do all of this in a short period of time.
Yeah, it's hard. Another medication which is newer is a Vioza that for hot
Mm-hmm.
flashes. I mean, it's pretty expensive and costly, and also then we have to do a lot of tests, liver tests. So I don't have
Yeah.
maybe two or three patients that tried it here. I don't know if you prescribe it to anyone there.
So I love Veoza. I think because it really helps with the hot flashes. But as you said, it is expensive, and so that's a big challenge because patients are being denied, or they're approved, but they have to pay $600 a month, and who's paying $600 a month for this medication? And so I think that for people who get it and whose insurance covers it, it's really beneficial. But you're right, it's liver enzymes every 3 months for a year, and so that it adds a little bit of extra effort. And but people do notice a pretty significant improvement in the hot flashes pretty quickly. But again, and I think there are other medications with additions. You've got SSRIs, you've got Veoza, you have things like gabapentin that can be helpful. You have oxybutynin, which is for overactive bladder but has benefits in hot flashes. So some of this is also figuring out, well, what else is happening, right? If you're dealing with overactive bladder, waking up in the middle of the night to urinate, maybe oxybutynin is the better choice for you. Whereas if also struggling with some mental health concerns, and maybe even Lifaxine is better. So I think pieces of that, just kind of putting that all together is important also.
And then low sex drive and dry vagina, which is one of the common, again, issues and problems, or genitourinary syndrome of menopause. So what do we do? Again, a lot of women still scared using local estrogen.
There's a lot of fear, and I will say that the guidelines really support using it from the American Urologic Association, from the National Comprehensive Cancer Network, and others. I mean, really all say that vaginal estrogen can be used. We know that the absorption is limited, and it really, you don't need to use a lot. It's a tiny, tiny amount that can be really effective. And so for patients who, I think it's a huge part of the treatment and can be really beneficial. But for patients who are nervous about it, we also have non-hormonal vaginal moisturizers, which are not going to work as well, but can be, sometimes we'll combine them with the vaginal estrogen. And then, there's also Intrarosa, or DHEA, which gets converted to estrogen and testosterone. So that's an option as well. So there are things, but really the data, and the reason these guidelines say that vaginal estrogen can be used is we have large clinical trials and looking at large amounts of patients that have shown no increase in the risk of breast cancer deaths from patients using vaginal estrogen. And we know that when you use vaginal estrogen, it reduces the risk of urinary tract infections and sepsis and hospitalization, which can often be more problematic than the original breast cancer diagnosis. So I think that, I think we just have to keep talking about it, and hopefully with time, more physicians will feel comfortable prescribing and more patients will feel comfortable taking it, because it's not, I will say, patients, I hear from people on social media all the time that they're told they can't have it, despite the fact that the guidelines are pretty clear on this fact.
Absolutely. I know time is limited, but again, another common question is about fertility during breast cancer treatments. How has it been affected? Am I able to have children in the future? Again, that's a very common question.
So great question. The big thing that we really feel strongly about is making sure that everyone is offered, fertility counseling and offered fertility preservation before starting treatment, especially before starting chemotherapy. This is really, really important. Every patient who's diagnosed should be counseled on how will this treatment impact their fertility. And we always think about that kind of in the concept of chemo, but we do know that if you need to be on hormone blocking medications for a few years, and let's say maybe you're already 38, 39, I always talk to my patients of maybe we should do fertility preservation before you start, so that we've taken, address that. Now we know we have the positive study, which looks at interrupting endocrine therapy after 18 to 24 months to attempt having a baby. And that study, in the short run, did not find an increase in the risk of recurrence. The study has not been around for a long time yet, so we don't have long-term data, but we know that in the short term, it did not increase the risk of recurrence. So we can counsel patients on that after 18 to 24 months, you're able to, and this is for early stage. And so these are really individual discussions based on the data that we have, the age of the patient, their risk of their cancer recurrence, and it requires a team. It's the oncologist, it's their gynecologist, it's their fertility specialist. It's all these people talking together with the patient at the center to think about, all right, what are your goals? How, if you do want to have children, how do we make that happen? What is the timeline of this? But it's such an important part that it starts at the beginning. Before we start treatment, it starts by talking about it then.
Great. And what about the lifestyle? The last question is the lifestyle, how that helps with prevention, and then once diagnosed with breast cancer, what else, supplements or any type of diet?
So lifestyle plays a huge role. One, it reduces the risk of recurrence. It reduces the risk of getting diagnosed with breast cancer. It also just helps us feel better, and it can help us tolerate the symptoms of a lot of these medications. So the big things that I talk about are minimizing or eliminating alcohol use. Kind of brought that up already. And one of the things too, it's not just the alcohol increasing the risk for recurrence or increasing the risk for cancer, but it's alcohol impacts our sleep. In perimenopause and menopause, it can worsen anxiety, right? And so now already you're struggling, you're on an aromatase inhibitor, and you're in menopause, and you're struggling with sleep, and you're struggling with anxiety, and then here add the alcohol, right? So it's maybe there's a lot we can't control, but we can control some of these contributing factors. So limiting/eliminating alcohol use. Movement. We got to move. And this is not, a couple of things. It's moving throughout the day. So it's not just sitting for 8 hours and, going for a 20-minute walk. It's trying to be as active as possible. And then it's getting your heart rate up when you exercise, lifting weights, cardio and weights. And I like to add balance work to this, because when we think about the impact of these medications on our bones, right? What happens if you have osteoporosis? Higher risk for falls? Well, got to work on our balance so we can reduce that fall risk. So strength, cardio, balance, and flexibility work. Diet. There's not one right diet, but typically a Mediterranean plant-forward diet is the way to go. Prioritizing protein, prioritizing fiber, healthy fats, complex carbohydrates, and limiting ultra-processed foods. Big part. And soy, minimally processed soy, we love. Okay, soy can be protective. We really want to incorporate soy into the diet, and may even help with things like hot flashes, which is kind of a very natural way to think about that. And then lastly, in terms of kind of lifestyle, I think of it as, what else can you do, right? It's like, can you sleep better? Can you manage your stress better? And some of these things are not in our control, but thinking about what we can control. Sleep hygiene, right? What are we doing right before we go to bed? Are we scrolling all night on our phones before we go to bed, right? So things like that. And often we can't manage the stress in our life, but we can manage our response to that stress, right? So these are kind of a little bit harder to quantify, but can be very, very beneficial. So lots of things that we can do for our bodies on a day-to-day basis. It takes time, it takes effort, but it can be so rewarding.
Yes, and I think we should, all of us, with or without diagnosis, follow such lifestyle. You mentioned about osteoporosis or bone health. Women with diagnosis and on treatment, any difference with screening? Do we have to screen more, or how do we go about that?
So definitely we want to start earlier. So anyone who's on any medication that can impact their bones, who's had chemotherapy, I 100% recommend getting a baseline bone density. Super important. And then typically if you continue on medications that can impact your bone density, like the tamoxifen and aromatase inhibitors, I do a bone density every 2 years. Sometimes annually, people already have osteoporosis and are on medications. But definitely we want to make sure that we're monitoring that really closely and then acting on it, right? So it's making sure, are we getting calcium and vitamin D? Are we lifting weights? Are we doing weight-bearing activity? Do we need to talk about medications like, Reclast or Prolia? So, really kind of thinking about all of those things together.
And someone is asking about soy milk. Their
Uh,
oncologist says no to soy milk.
I mean, this is, so it's just like the endless debate, but I will tell you the data is really clear that soy in its minimally processed forms can be really, it can be protective and it's not
Yeah,
going to
it's a
be
fiber
harmful.
estrogen. Yeah.
Yeah, and so soy contains phytoestrogens, which are plant-based estrogens, but they are actually protective. And I have a whole video on couple of videos on soy and flaxseed that people can check out, where I really go into that data. What we want to stay away from is like really heavily processed soy, and things like the soy nuggets, that get marketed as
Mhm.
really healthy, and they're just full of added stuff. But miso, edamame, all of that we feel very comfortable with. And soy milk, as long as it's not heavily processed, doesn't have a lot of
Mhm.
stuff, we're super supportive of that.
Yeah, I totally agree.
Mm-hmm.
Yes, that's great. And where can, how do you see patients? Is
Um,
it just local, or if anyone wants to contact you from our side, are you
yeah.
responding, or any,
So
um,
I see patients locally in New Jersey. I have a pretty busy practice. But they do have to, they are in person or virtually, but you have to live in New Jersey due to our insurance and
mhm.
licensing rules. I don't have the bandwidth to answer DMs or, specific medical questions, but I do read all the messages I get and try to post videos that answer some of the questions in a more general way. But I always stress, as you do as well, that social media is, it's not medical advice. And if I can't give medical advice over the internet because I don't know the whole story and I don't have
Exactly.
all the information. And
Yeah.
so I think the key is really finding an oncologist that you feel comfortable with, that you
Mhm.
can talk to, and so that you can push back and say, okay, well, in this case of the soy milk, can you show me the data, right? Can you show me the
Mhm.
evidence that says I can't have soy milk? And just hopefully having that shared decision making.
Very good. It was lovely,
Thank you.
short but sweet, very
Yes.
informative. It was great. And if anyone has any questions, or they can come and watch your videos, all very educational and insightful.
Well, thank you for having me. I think we got a lot covered in 30 minutes, and hopefully this was helpful. And you're going to save this, right? So people
I
can look
will,
at it
and I will
later. Yeah.
share. Sure,
Perfect.
absolutely. Thank you very
Thank
much. See
you.
you soon. Take care.
Bye.
Thanks, everyone. Bye
Thank
bye.
you, guys.